Hello, everyone. Welcome to Mom's Corner. I hope everyone's doing well today. My name is Zainab. I'm your host, and I'm so excited to be here with you today. I want to thank everyone for joining us. We are so honored and blessed to share this space and time with you. For those of you who are regulars on Mom's Corner, thank you for being here. And for those who are joining us for the first time, which hopefully that will be soon, more people, welcome and thank you. And a big thank you to our amazing group of doctors, Dr. Helena and Dr. Zaina. Mom's Corner is one of the many programs under the umbrella of Global Perinatal Services, or GPS. And GPS is a nonprofit organization doing amazing work and changing lives every day. Our mission is to provide community-based doula services that will educate, respect, and empower low-income Black, refugee, and immigrant women and their families during pregnancy, birth, and into early parenting. Mom's Corner is a space not just for moms, but for all women folk. At GPS, we believe that motherhood is an extension of a woman's identity and not the definition. And the Mom's Corner, since the pandemic, has become not just a space where we come together to find empathy, support, and camaraderie, but a safe haven and access to so many critical resources in our communities. And today's topic is women's annual wellness exam, aka the physical. And and our doctors will take over in a few minutes, and I just want to welcome them and thank you so much for being here. So, if you have any questions, please leave them in the chat box or send it to me privately. Thank you.
Great, thank you, Zainab. Hi, everybody. I am Helena, and I have Zana, my colleague, with me today. We are both first-year resident physicians with Swedish family medicine. So we are just getting started in our training of becoming future primary care doctors. So we do a lot of annual visits, and one of the main goals of primary care is to keep our patients as healthy as possible. So these annual physicals, wellness exams, really allow us to touch base and make sure that we're covering all of our bases and screening our patients for common things that we can catch early and prevent chronic diseases from forming as well. Throughout the presentation, we will be intermittently using the term women to recognize, and we recognize that this is not an inclusive of all identities. This is meant to think of wellness more comprehensively. As we go through the presentation, we will discuss screenings that are specific to body parts and hormone exposures as well. And we would love this to be more interactive. So we have a couple of sessions that have more questions and would love the audience to participate and share their experiences if you feel comfortable to do so. So we'll go ahead and get started. So the first thing we want to kind of have a discussion about is why everybody thinks an annual wellness exam is important. What experiences have you had in the past during your wellness exams? What topics were you able to address with your provider? What questions have you been asked, and what have your overall experiences been like?
I think for me, the annual exam is kind of just to make sure everything's working properly, like there's nothing new going on in your body, and just for every stage to kind of make sure like I'm up to date on whatever tests I need to have done and routine exams and things like that. Just to be on top of things, even if you are healthy or you feel like you're healthy, it's important to go in.
Absolutely. Something that I have noticed as a provider pretty early in my training is that I really appreciate my patients' time being able to come into the office and see me. And sometimes it's for a problem visit or they come in with a problem that they specifically want to talk about during what we would have scheduled as an annual wellness. And I think this presentation is also to highlight that these wellness exams are should be focused just on talking about preventative medicine and the screenings and keeping you up to date on all of the labs or imaging. And then follow-ups can be about problem visits too. Sometimes if we have time, we can do a little bit of both, but I think the expectation is usually to maintain focus around the topics of screening.
And I see a comment here. Danielle said, usually a PAP, blood pressure, weight, and any concerns. That's it.
Mhm,
Thanks for
absolutely.
sharing that.
Okay, great. Then we can continue forward.
Great. So I put in the chat a link, and I can send it again because sometimes when people have joined after, it won't show. But this is an interactive way to look at some of the screenings. And there's kind of different ways to look at it at the website. So if everyone wants, if you have the ability to just pull it up and take a look, I won't spend a long time on it, but I just want to know that this is a resource. And I'll draw your attention to, and I know it's a little small, but some of the things that we do at wellness exams at every visit. So there are certain things, and we'll go through a lot of them that happen at certain ages specifically. And then there's certain things that are cross-cutting themes that go across them. So some of the things that I put in the boxes here. So it's for every visit, for example, we do alcohol use screening and counseling, anxiety and depression screening, blood pressure screening, as Danielle mentioned, and then also thinking about interpersonal and domestic violence screening that should be done at every visit, especially well person visits, but just at any visit in general, and I'll talk a bit more about that. And then obesity screenings, that's usually done by a weight and height, often just a weight realistically. And then talking about substance use and tobacco. So those are done on kind of all, they're supposed to be done at all well visits. And then there's certain things that happen kind of depending on risk factors or depending on age that are not boxed out. But if there's a certain thing that you're seeing, please shout out if there's something that you're seeing on this list that you feel like you've never been asked about. I'd be curious to hear. And feel free, you can put it in the chat or shout out, and you can interrupt us at any time and just join the conversation. Okay. I did myself on accident. Just a little bit of background kind of about who decides a lot of the timing and what screenings are covered. So the wellness visit is your annual visit that you get that's free per year, usually. And that's what things are covered and recommended is in the US done by the US Preventive Task Force. And so I think it's interesting just to hear a little bit about who makes these decisions. So it's been around since 1984, and it's a volunteer panel of national experts in prevention and evidence-based medicine. And it's something where people are nominated and then appointed for 4-year terms, and they're not paid, but they're basically come together and review all the literature and then come up with certain recommended screenings that they'll say kind of, they do it by grade. So like has the most evidence is grade A, and then they'll kind of go down by there of things that they recommend to be done. And so those are kind of things that we think about in terms of like, okay, what things would be important for us to make sure that are included in wellness visits. And then the next thing is kind of talking about detections of cancers. And one of the things with cancer and the reason of why certain cancers are selected and why not comes down to, if you were to detect it early, is there something that could be done about it? So we'll talk about cervical cancer after this. And one of the reasons that cervical cancer is one of the cancers that can be detected, it can be detected early, and there's really great treatments for it, especially if it's detected early, versus something like ovarian cancer, where there's not a great way to detect it early before there's any symptoms. And if you were to detect it really early, there's not a lot of evidence to show that there would be effective treatment that would necessarily prolong someone's quality of life and length of their life. And so that's kind of where all of those evidence pieces comes in, of choosing what cancers are recommended to be screened or not. And also kind of the timing of what cancers need to be screened depends upon, if you were to detect something really early, would it just end up causing a lot more harm in terms of extra tests, the emotional and financial burden of having to go through that process. And so that's kind of, they take a lot of that evidence and come up with their recommendations. Okay, we'll move on to talking about cervical cancer. So just a little bit about that. So cervical cancer is, a few statistics, is the fourth most common cancer in people in the world, ranking after breast, colorectal, and lung cancer. In the US, the incidence of mortalities of people who have been dying from it has been declining very significantly because of the HPV vaccine. Oh, I'm seeing that. Oh, perfect. I see. Thank you for saying that. I'm sending that out before. Because of the HPV vaccine, but also because of pap smears or cytological screening programs. And so, but there continues to be, as you can see in this slide, a lot of disparities that are geographical in terms of cervical cancer in the United States. And the darker color being where there's more people that have cervical cancer. And then there's also really significant disparities in the US around racial and ethnic disparities for cervical cancer. And so in the US, Hispanic women have the highest incidence of cervical cancer, followed by non-Hispanic Black women. And overall, Black women are more likely to die from the disease than any other race or ethnicity. And so that's something to really be, that we think a lot and is important to discuss. And then I put some risk factors that we kind of think about it that increase the risk. So this is a time to ask you all. So how do we think about prevention of cervical cancer? What have people heard about options to prevent cervical cancer?
The HPV shot.
Yeah, exactly. So the HPV vaccine, or Gardasil, is a vaccine. Yeah, thanks. Yeah, definitely. So the vaccine is something that is relatively recently developed, and it's recommended for routine vaccinations starting around the age of 11 or 12 for anyone, but you can get it as young as, when I was just looking at it, it said 9. But the point is to try to have it before initiating sexual activity, although that should not be a barrier to getting it. If you already have been sexually active, doesn't mean that you shouldn't get the vaccine. And it's typically 2 doses, and you get them 6 to 12 months apart. So you can imagine that sometimes it can be challenging for people to have that follow-up. But if you end up getting the shots with a further distance apart, you can get a 3rd shot as well to complete the dose. And then they recommend, what age do people think about in terms of when we start doing pap smears, what you think of as like for cervical cancer screening? Yeah, thoughts of, I can give some options. 15, 18, 21, 25.
I would say 15.
Okay, I'm seeing a lot of answers in here. I'm seeing 15. They started me early 16 when sexually active. And then I see also 18. Okay, I'm glad that we're talking about this because there's been a lot of changes that have happened. There's been, I think I can say, even when I started getting screened, it was I think the what I was told was like when you start to be sexually active or 18. And I think what ended up happening was they were finding a lot of the time people would be HPV positive or have an abnormal pap smear, and ended up having a lot of kind of going back to this the screening question of like there was a lot of times where people were getting unnecessary additional procedures like colposcopies where you take a biopsy out of the cervix, and they were getting all these extra procedures because they were coming back being HPV positive or having abnormal pap smear. And so a lot of work and research was done in recent years to change the recommendations. And so now the recommendation is to start at the age of 21. And so that's when we do pap smears starting at 21 and not any time before that. And that's because people were just ending up getting a lot of really unnecessary procedures and emotional stress from having abnormal paps at a young age, when often it was found that the body was able to clear a lot of HPV that they were exposed to early on. And so starting at the age of 21, and then between 21 and 29, you can get, it's just the pap. There's kind of been a lot of back and forth about this, but as of now, you can get the pap smear, which is just the brush that goes along the cervix. And then after that, after the age of 30, you can get you can get the pap smear plus HPV testing. They're called co-testing. And so you can get both of those. And that ends up being that you can get the pap smear every 5 years, both of them together. So that's been if they come back without any abnormalities. And so that's really nice because it just spreads out the distance that you need to do it, because they found that they're able to detect a lot of things with the combination of those. And there's a lot of continued movement still to try to even change those recommendations to be just HPV testing in the future. And so I think it probably will change, but I don't think the age of when it's going to start, I don't anticipate it changing very soon.
So the HPV shot is not hinged on being sexually active. Like you don't have to be sexually active to get it. Is that what?
That's correct. Yeah, it's not based on being sexually active. They just, in terms of the HPV shot, it's recommended that that's why they just are encouraging people to get it when they're younger, before you can be exposed, just because it will give your body more of a chance to fight things off, the viruses off. But at the same time, you don't need to be sexually active to get it, or it's still important to get.
Yeah. I was wondering, why do boys need to get it? Because I noticed now boys are recommended to get it too. Just wondering why that is.
Because HPV can be passed along through through people who have penises, and so that can be, it's important, even though there's still not a lot, and there also can be HPV. And now that I'm thinking about it, Alina, I don't know if you know, in terms of like incidents within people who are male, if they can get, I don't believe that you can get HPV, because it usually, or the most effective it is on the cervix. That's what they found in terms of what I've been taught, but it can help prevent it spreading to your partner.
So it's transferable then to your partner. That's why. Okay. Got it. Thank you.
Yeah. Great questions. And then this is just a summary of just talking about the various options for screening that we talked about. So just the pap smear, or the pap smear plus the HPV testing, and that you can get that kind of spreads out how much you need to get it.
Great. So we will move on from cervical cancer screening to breast/chest cancer screening as well. So just a little bit of background. The lifetime risk of developing chest cancer is quite high. It's about 12% in people who have breasts. That's about 1 in 8. But the good news is that the 5-year survival has actually improved a lot, significantly, due to the screenings that we have, the detection, being able to detect breast cancer and then treating it as well. This little graphic shows the mammogram that I know is commonly dreaded by people to get. It's not comfortable at all, but just know that from these statistics, we know that it's doing what it's supposed to do in terms of detecting early and intervening early as well to have better health outcomes there. And just as we have the disparity with cervical cancer, we also a lot of other health problems in the United States, we see similar trends in chest cancer and the survival rate of that. So this graph is showing throughout most states, I would say, in the US, and the mortality rate based off of race throughout the US. So it's showing that Black women are more likely than white women to be diagnosed with breast cancer or chest cancer. And then also that means later down the line being able to be treating it. And even though we have seen the statistic that it is getting better. So very much something to keep in our minds, that this is something preventable and that we should continue to encourage our women with a specific mindset to really encourage Black women to be able to, and encourage them and support them to get the screening to close this gap. And then in terms of recommendations for screening, it is, there's a lot of different recommendations for this one. We have recommendations from the what we call ACOG, the College of Obstetricians and Gynecologists, the U.S. Preventative Service Task Force, which makes a lot of recommendations that we're presenting on in this presentation, and then American Cancer Society. They, in the past, I think we have seen lots of clinical breast exams in the office where the doctor will feel along the breast, feeling for masses. And also there was the recommendation to do home breast exams as well in the shower or whenever you can. And that has fallen off a little bit. I would say the USPSTF says that there's insufficient evidence to recommend this for people with breasts. And then ACOG, the obstetricians, say that it can be offered. This is all about shared decision making with our patients and seeing if it's beneficial or if it's something that they would like to continue to have done. For the mammograms, the time to start is also different recommendations from different people. So from the OB-GYNs, we see that they recommend starting earlier, starting at the age of 40, and then screening every year or every 2 years. And then the USPSTF has actually pushed that recommendation a little bit further out to starting at 50 years old. And I think that was based off of a study that was showing that, similar to cervical cancer, we were picking up a lot of different masses, things that are questionable on mammograms. People with breasts had to go and have biopsies and other interventions that were distressing and anxiety inducing for it to be more benign or something that the body can also just self-resolve. But just given how sensitive we're able to detect these, I think ACOG has stuck with the starting to screen earlier. And I think in the end, the overarching message, I would say, for chest cancer screening and also all screenings that we're talking about is that these decisions should be made individually between a patient and their doctor, knowing what is best for them, and then also taking into account family history, because we know that there are certain genes that predispose people with breasts to getting breast cancer, more aggressive types of breast cancer. So being able to take the patient individually as a whole person and their individual experiences to make the decision on when to screen and at what interval to screen as well. Okay.
Great. So the next cancer that we'll talk about that we include in these visits is colon cancer screening. And I'll pause there. So typically we start between the age, that's fine, we showed the fit between age 50 and the screening happens between age 50 and 75, and I'll talk a bit about when that happens earlier. What types of screening have people heard of for colon cancer screening?
Colonoscopy.
Colonoscopy, yep,
Mhm.
that's definitely one of them. Anyone else heard of any other types or have had people mention?
Is there a test that they collected the feces or something like that?
Yeah, definitely. Yeah. So there's another test that can be done. So there's kind of two tests that are from where you someone will leave a stool sample, and there's a test done on it. And then I'm also seeing endoscopy. Yes, exactly. So we call it sigmoidoscopy, or a camera that goes into like part of the colon but doesn't travel the whole kind of area, which is what happens during colonoscopy. Great. Yeah, so now you can go to the next. It will hopefully show the table. Perfect. So there is just kind of a little bit of background while I have that up, is to talk about why we do colon cancer screening. So colon cancer accounts in the US for about 10% of all cancer deaths. So that's 1 in every 10. And it's the reason that it's important to do the screening, and kind of the why the interval is as long as it is between them, is that the majority of polyps, or kind of these small masses that can grow on inside the colon, take a really long time to develop, on average around 10 years. So they've done a lot of research around kind of what would be the right timing to go through this type of procedure, and they found that around the age of 50 is when they can start to detect and then be able to do that every 10 years for the whole colonoscopy, which can be a really intense process for people to go through. I don't know if anyone here or have had family members that have done a colonoscopy, but it does require some planning in terms of, and it can be limiting for some folks because you need to take something to, you know, you take something that makes you poop a lot essentially, and you end up having to clear out all of your colon, and then you have someone, yep, go light, I'm seeing, exactly. So it can be really intense, and then so that's the day before, and then going to the procedure, you are sedated, so you are not usually totally out under anesthesia, but you are very sedated, and so you need someone to pick you up after it, and so that can be really limiting for folks in terms of, if you don't have someone that could do that, or in people who struggle with transportation. I know there's been a lot of people who have done a lot of incredible work trying to increase access to colonoscopies, because it's been shown to be really incredibly helpful for preventing colon cancer, but there's still a lot of barriers for people. And then, so that's why there's these other options. So kind of going for the first one, the FIT test, which is something that we as a clinic have been doing a lot of quality improvement projects on. And that is something where it's done every year, and you leave a stool sample. You can, now there's home collection tests where you can get them and then you can just drop it off at a lab, but they'll mail it to your house. That's what one of the projects that's happening. And so you can kind of do it on your own time, and you don't have to go and then come back. And that's done every year. But the idea is that you can detect small amounts of blood. And then the thing about it is that if that were to be detected, then you would do a colonoscopy, but it's a good way that you can have the option for screening. And so it's a conversation, kind of like as Helena mentioned, that's always shared decision making with your provider, where if you were to have a positive test, would you want to get a colonoscopy? And if someone says absolutely not, there's no way that I would ever do a colonoscopy, then sometimes it's a decision that people don't want to be screened, and the FIT test might not be even an option for them, because it's can be really challenging to get the result. And then if you're not going to do anything else beyond that, um, I think that's just a decision that people can talk through. But that's a conversation I usually have when I offer that option. But I think it's a really great option. And then something else that you can do is this dual DNA test that I haven't seen very often as an option for patients in our clinic. And I don't know if Helena or anyone else has seen that offered as much, but I know that I've heard of places that have that more readily available, and that you can, I believe, leave a stool sample as well. And then the sigmoidoscopy, which is can be combined with so it's a less invasive procedure, and then it can be combined with a fit test. So that's another option as well. And then I'm seeing a question here. Could the presence of blood be another reason other than cancer? Yeah, that's a great question. So it definitely could be another reason. It doesn't necessarily mean that it's cancer. There's other reasons people might have blood. It could be blood due to, say, stomach ulcer. It could be blood due to inflammatory bowel disease. There's a lot of reasons that people might have blood in their stool, but as doing that test, it's a way that you would then make sure to then have follow-up to make sure that it's not colon cancer. And maybe sometimes in that process, say it is inflammatory bowel disease or something like that, a colonoscopy can be helpful in being able to look at that. And so sometimes the workup is kind of the same. But yes, it doesn't necessarily, if you have blood, equal cancer. Not at all. Any other questions or things for that?
That is a great question about the blood in the stool. And I think another a good thing to point out is that we start the recommendation to start screening at age 50 because we know that as we get older, we're more predisposed to get colon cancer. In people under the age of 50, blood in the stool could also be hemorrhoids and anal fissure, things that are more common. And so we think less that it could be cancer related. But even sometimes those with blood in the stool who are younger than 50, if there are concerns for cancer, there's a family history. Screening can also be done earlier as well.
Thanks, Lena. Actually, I realized I didn't say what I was going to say a little bit more about the family history piece. So the 50 is kind of the, thanks for the reminder, the 50 years old is kind of the general, if you have a quote unquote average risk of having colorectal cancer. But some of the reasons why you would get screening earlier would be that makes someone's risk higher than average would be a personal history or a family history of colorectal cancer, or polyps, or a history of inflammatory bowel disease. So that puts you at higher risk of cancer, of colon cancer. And then a family history of of certain like cancer syndromes. So there's some called like familial I always say the word wrong, but adenomatosis. It's a word that I never can say. But it's a condition where you can have a lot of polyps form that are hereditary. And then there's also certain other conditions like Lynch syndrome and others that can predispose you to cancer as well. And so if you have that in your family, or if you have a known history of that, then that was something that would make it so you would get that screening earlier.
Doctor, I know there are some stomach cancers that are not detectable. Is colon cancer one of them? I've heard people say you don't. Some people don't catch it until it's too late. Is that the case with colon cancer?
Yeah, that's a great question. So, there's always a chance that it could be missed or it's not being caught. But the reason that the recommendations are as they are is that they found that the most people were able to have that be caught early. And because it takes a long time to develop, typically, if you can go in and have that kind of the initial screening to make sure that there's nothing developing, that it can be caught early. And also when they see these polyps, which are little growths inside the colon, they take those off. So it could not be cancer at that moment, kind of like how a mole, sometimes there's certain moles that will take off just because we are worried that potentially it could become cancer. And so part of it is looking and taking a look at that area. But part of it is also, it can also help with prevention because they will remove polyps. That's a great question.
Mm-hmm. And I think this has also been in the news a lot lately too, because of earlier
people having colon cancer earlier and actually missing it. I'm thinking of like Chadwick Boseman right now after seeing Black Panther.
Yeah, absolutely.
But I think last year, I have to double check, but I think the US PFTF, that big overarching group that makes these recommendations, has also, they recommended that I could also start at 45, but I will need to double check that. A great question. Let me see. So I will talk a little bit about lung cancer screening. This is not one that we recommend everybody to get. You can see that the guideline right now is recommending that adults, male, female, anybody who is age 50 to 80, who has a 20 pack year smoking history, and is a current smoker, or who has quit within the past 15 years, get a lung CT annually, so every year, to screen for lung cancer. And this is just based off of the knowledge that we know that smoking and lung cancer are so closely related that it's worthwhile to have these annual screens to see if and when it develops, and then to be able to intervene early as well. But this is not something that you need to worry about if you do not meet those criteria. And the picture is a little cartoon of a CT scan. And so those are the current recommendations for all of the cancer screenings that we talk about. But we'll move on now to other topics that we discuss, things that we want to screen, prevent, and detect other health conditions. So this is along the lines of infectious disease, cardiovascular disease, chronic diseases, osteoporosis, and then other topics that you can discuss with your doctor. So I will start with infectious diseases, including sexually transmitted infections. There are lots of different things that we can screen for, and there are a lot of STIs that are not commonly screened for, and that's because the ones that we have decided to continually screen are ones that don't always have early symptoms. So something that you might be carrying that might not develop symptoms until further down the line when it could have been prevented earlier. So kind of along the same lines as the cancer screening. So something like herpes screening is not done annually unless if you have symptoms, because when you're symptomatic is most likely when we'll be able to test for it. So here are some that we do screen for. So chlamydia and gonorrhea, we screen everybody who is under 25. Those are annual screens when they come to the wellness visits, and then anyone over 25 who's at increased risk. And there's a lot of different criteria to classify somebody in the increased risk category. For syphilis, we screen those, again, at increased risk over those who are over the age of 13. Hepatitis C is just once in your life. And then things like HIV, Hep B, TB, those are screened for anybody who is at that increased risk category as well, age 15 to 65. And I think that is also like clinic dependent or state dependent as well. I know in my clinic, we do screen for HIV and Hep B pretty consistently, everybody, and that's not for people who are just at increased risk. So I think it also depends on where you are. And these are also some things that you can go to your doctor and ask to be screened for if it's not something that they are recommending during that time.
Great, thank you. So something else that I think it was brought up earlier on in terms of things that happen at most visits, is your blood pressure. I think that's one of those things, like when you go to the doctor or you go to a provider, they check your blood pressure and you don't think much of it usually, but the reason that is and why it's done at basically every visit, especially at wellness visits, is that having good blood pressure control and and when catching it early also, that you have a really decreased risk of having long-term cardiovascular complications like heart attacks, strokes, vascular disease. So they've found such a positive result of screening for that really regularly in people. And then for diabetes screening, typically it's the standard is to start screening for it with at the age of 40, but often people will kind of depending on various factors, family history, it depends on obesity and all these other risk factors that people might have, or if people are really concerned about it. I often will screen earlier in people, but the official recommendation is starting at age 40. And that's done with a blood test called an hemoglobin A1C. And that's a test that looks at how much sugar on average is on your blood cells over a 3-month period. So, and if someone does have diabetes, we typically check that it's supposed to be every 3 months to be able to see the average of how people's blood sugars have been. And so that's the main screening test that's done. And then kind of in terms of other things, it really depends a lot on the provider. So if someone does have, for example, diabetes, and some people will include chronic disease management as part of the wellness visit. So something like a diabetic foot exam or getting certain labs as part of that visit. And so, or talking about hypertension, getting labs related to their hypertension. So that's often like a test of urine and looking at how much, and that's also done for diabetes, protein to creatinine, we call it. So looking at like how your kidneys are functioning and filtering out things within your body. And so that will be something that's done as well, often by certain providers. So it kind of just depends. Sometimes how much of the chronic disease management is done or if that's done at a separate visit, but the basic screening tests around it are part of the wellness visit standardly. And then if you go to the next slide, this is an example of a screening tool. So this is related to cardiovascular disease. And if someone, and this helps to guide management around baby aspirin. So there's been a lot of this stuff, and it can be challenging to keep up with what the recommendations are. But there was a period of time when almost so many people were put on aspirin, and baby aspirin is a term for a low dose of aspirin, 81 milligrams. And so there's been a lot of debate and back and forth about it, but essentially the current recommendation is that you calculate the long-term risk of having a cardiovascular event, for example, a heart attack. And if that's 10% or greater, then it's recommended to start baby aspirin. You can go to the next slide.
All right. So another thing that we screen for is osteoporosis. And so the recommendation right now is that all women over 65 and older should be screened for osteoporosis, given with what we call a DEXA scan. It's a dual energy X-ray absorption. Oh, that word. And that will be of the hip and of the lumbar and the lower spine. So we just know that as we get older, our bones get a little bit more brittle, and just to catch any osteoporosis early and being able to intervene with medications just to make sure that our bones stay strong in the future. And then also there have been studies that show that falls later on in life are really correlated with mortality and your survival rate. So a fall can be very detrimental to our elderly. So it's just something that we want to prevent. And then also not only women 65 and older, but under 65, if they have this an estimated 10-year risk for fracture that is equal to somebody who is 65, then they can also get this DEXA scan as well. And so the risk factors are listed here in this questionnaire that I have on the slide, showing that if you've had previous fractures, if you had a family member with a hip fracture, if you are a smoker, if you have taken steroids recently, if you have rheumatoid arthritis, or if you have any other sort of osteoporosis, to go ahead and get the screening and to intervene if something is caught. And this tool is the FRAX tool, FRAX, and it's listed at the bottom there. And then also something that we want to check in about every wellness visit is vaccines. So not just for our kiddos, but for us as well. Every year we can get the flu vaccine, and we encourage it as well. And as COVID continues with newer vaccines and boosters, we would recommend getting the COVID. And it changes so quickly that I didn't want to list something that would become out of date. So just as recommended, the CDC has great resources that they current and with the most recent guidelines as to who qualifies for a booster or a vaccine as well. And then the Tdap vaccine, mainly for the tetanus, it is recommended every 10 years. And then there are other vaccines like Hep B that can be given as well. And those are not necessarily recommended in a schedule, but something to discuss with your providers.
Before I move on, I'm curious if people, in terms of like screening for depression and substance use, if there's ways that providers have screened for these topics that you felt that you really liked or you didn't like. So if anyone has any examples of kind of wording or ways that people were asked about these topics that they felt was great.
And sometimes my providers just kind of come out and say it. I don't think I've experienced that in the past, but they actually just come out and say, "Are you feeling depressed?" Or like some questionnaires I had to fill out for a migraine. So that was one of the questions, do you feel sad? Do you find yourself contemplating, like hurting yourself or something like that? Yeah, so I really appreciate that about that, the different ways to ask that question.
And it sounds like you liked kind of the direct approach, if I'm hearing that.
Yes, it was kind of surprising, but I like that direct approach. Yeah, definitely.
Great. Anyone else? So, and you can feel free. Didn't like having to fill out the form. How often did you feel low? And then how often it kind of felt like it was easier to say lower options in denial. Yeah, I think thanks for sharing that. I think that it's definitely something that varies a lot by clinic and kind of approach. Some people will ask it in the visit, as you mentioned, and then some people it's kind of built into visits in terms of this is specifically around depression. So talking about a survey or like asking in person, and then sometimes like medical assistants or other providers will ask it ahead of time. And I see Danielle saying, I've had them, not a big fan of them. And I don't know exactly what them, if you mean the survey or if you mean the people asking it. But I definitely think it's something that's really important to screen for. And I often, if I have someone that I'm caring for that has experienced depression or anxiety in the past, and I know how they have a history of it, I actually will screen them at most visits. Okay, oh, perfect, thank you, the PHQ-9 and GAD-7. So I will screen people at most visits kind of as like a conversation starter, but I recognize that it's not a perfect test. And I think that sometimes can feel impersonal, especially if you don't have any follow-up or conversation about it. But that's typically how we'll do it is there's a 2-question one that people will get, say our clinic will get when they register as new patients. And then it's recommended to have that, at least those 2 questions asked annually. And then there can be a follow-up screening. The PHQ-9 is for depression, and then GAD-7 is for anxiety. And then for tobacco screening, it's also recommended that to screen everyone annually in terms of what they have tobacco, and that's important more and more to also include saying tobacco, vaping, or any other tobacco products, because often people think of vaping as not cigarette smoking or tobacco. So kind of making sure that I always have to remind myself to ask the question really inclusively. And then alcohol, asking about screening about how much alcohol people have per week, per month. And then and then asking about other substance use as well. And I think with any of this, just what I always try to think about and work to continually improve is asking things really non-judgmentally with anything that we are asking people about that can feel sensitive to people, just like making sure to ask things in the most non-judgmental way as possible. And I often say if it's something related to alcohol or cigarettes, I will give people options that are not only low. So for example, like if I'm going to ask someone how many drinks a week they would have, I would say 0 drinks, 40 drinks, 20 drinks, like give options that are, that have various levels. So people don't feel like they have to anchor at like 1 or 5 and then feel really ashamed if maybe that number is much higher for them. And then that's something that, yeah, you can go to the next slide. I just make sure to I actually screen for it at most visits, but at minimum, this is a really good time at the annual visit to talk about it. And then something that is also is really important to include, and I put some statistics here to kind of to think about it, but 1 in 5 people have experienced severe women have, and 1 in 7 men have experienced severe physical violence from an intimate partner in their lifetime. And women between the age of 16 and 24 experience the highest rates of intimate partner violence, almost 3 times the national average. And then in terms of other populations, 43% of LGBTQI plus youth reported being victims of physical dating violence compared to 9% of heterosexual youth. So just ensuring that we make sure to really screen everyone and be really inclusive when we ask that question. And I think, some people try to include asking this at every visit, and a minimum at new patient visits and also at the wellness visit can be a good kind of time to do that. And then there's different ways that people ask it, and I would love to hear if anyone has ways that they've been asked or that they felt like was a good way to ask it. Some examples could be, do you feel safe and respected in your relationships? Or asking and normalizing that you ask that to everyone so that it doesn't feel like something targeted towards them, and just allowing people to have that space. And also just offering resources, and also to say that you can be a place that people can come and talk about it, and not trying to force it out of people if they don't have developed that trust yet. But I think that is something that's really important. So I just will pause here and see if people have any thoughts around if they've been asked this question they thought in a way that they felt like was helpful or effective.
I always get the, do you feel safe at home? Are there any weapons in the house and things like that? Yeah.
And do you like the way that is worded? Do you feel like that's a helpful way?
Yes, because it's direct and it doesn't beat around the bush. So I like that, the way that's asked. Yeah, absolutely.
Thanks.
As I was wondering, as providers, is there a time when you ask that question and the person is kind of like withholding information or lying? How do you help that patient? I mean, you said you give resources, but is there something beyond that you do?
I can speak a little, and I think I see Helena's mic is available too to answer that. But I would say that a lot of time, if someone if I have a sense that there's something that they're wanting to maybe share, I can sense that, I just try to emphasize that this is a confidential space, and I can say offer some resources and schedule a close follow-up, and sometimes just bringing up the conversation and then knowing that you can have a follow-up, and maybe someone needs time to think about and process and determine if they feel safe to talk about it with you. I think just like bringing up and saying that this is a topic that is part of the care that we can provide, and just like leaving it at that. I personally like my approach is not to try to push it at all, but I just like state those things and let people know that I'll be there if they want to talk about it.
Mhm.
Does it make a
Yeah.
difference if they have a child or if they're alone to your approach? Does that, factor into that?
In terms of asking the question or screening for violence?
And now in terms of like knowing that information is being withheld and how much of support can you offer that person? If they were alone, that would be a different story, but then there's an infant or a baby in the picture.
Yeah, I think my approach is similar to Dana's, where I usually, if I'm suspicious of something, or if I just feel like I need to be able to speak about violence just in a general way, maybe not even directed towards the patient, just to explain what we have in the office in terms of social workers, resources, places that we can direct anybody to if they're experiencing this, especially if a child is in the room. I think definitely gauging that relationship and seeing if we're able to speak about this, and if the patient is comfortable to speak about this too. I've also used MyChart, actually, the online platform, to speak with patients about this topic who feel more comfortable being able to just type it and send it. So I think there are many ways, but it's a good question about what I would do if the patient is not very forthcoming in the setting of experiencing violence at home.
And I will say also that as it is sometimes challenging, as we are mandatory reporters, so like for children. And so if there is a major concern about a child's safety, it can be a really challenging balance to walk in terms of like letting people know that if we are concerned that a child is being hurt, then we have, like, as by law, we have to report it. And so I think that is something that honestly I haven't had a lot of experience with yet early in my career, but I am sure that will come up a lot as we continue to care for more folks that unfortunately experience a lot of violence. And so I think that just that is something to name, and that it's a really challenging situation.
Thank you. And I hope that you never have to encounter that situation, both of you. But thank you for answering that.
Okay, and the last thing that we'll touch on is just overall lifestyle topics that you can discuss with your doctor. I think I just really want to echo what Zana was saying about how this visit itself and all your visits with your doctor are confidential, and just a safe space to ask questions and to discuss any concerns that you have. Some things that we ask, I feel like sometimes it can feel a little bit invasive, can feel sensitive, but just know that the reasons why we ask them are just to focus more so on your overall health and to prevent any bad outcomes in the future. So along those lines, just talking about nutrition and healthy diet, lifestyle changes around that, being able to set SMART goals in the clinic is something that I have liked to do, just in terms of cutting down on how many sodas you're drinking. Like, let's go from 5 sodas a day to 3 sodas a day, just starting with numbers that we can work with, and to be able to meet patients where they're at in terms of things that are really difficult to change, just our daily life, things that we have built habits around, just to try and encourage, healthy lives and to prevent chronic diseases. That's similar for exercise as well. And then sexual health is something that is important to discuss, not only to screen for infections that we had previously talked about, but also just about your general experience with sex, sexual pleasure, being able to have open communication about this and to answer any questions that come up, because sex is the normal part of daily life, and it should feel comfortable to ask your doctor about it if there are any concerns. And with that, we would like to thank everybody for your attention and to have these discussions with us. It is, they change, these recommendations change every day, and as the years go on. So there will be things that will develop in the future that are new, and some things that we're doing now might fall out of practice as well, as we've seen. But we would love to answer any questions that anybody has, or any last thoughts about what we had discussed today.
This was such an informative and educational session as always. Thank you so much. I think you answered most of the questions I had, so I have a few lingering, but I'll let our guests ask if they have any questions.
Thank you so much for everyone who attended and people who may watch this in the future. And we're happy to, if anyone has follow-up things as well, to reach out to us. We can send along our email addresses to be shared. Absolutely.
Yeah, one of the questions I had, doctors, was with osteoporosis for women who are pregnant with boys. I've heard questions like their bone density goes down because you're pregnant with boys versus girls. What is your take on that? I was curious to know about that.
Oh, I'm sorry. The question is about the bone density for males versus females with time, or?
Yeah, or like women who have children, boys are more susceptible to osteoporosis versus women who are girls who are pregnant with girls.
Oh, I have actually never heard that. Zane, I don't know if you have.
No, I've never heard that. So I would have to research and see if that's something that has been studied significantly or not. I'm not sure. That's a great question. We can get back to you with that answer.
Thank you. Yeah, I appreciate that. And then going back to the wellness visits. You may have mentioned this and I missed it. How can people get prepared for that with their wellness visits?
It's a great question as well. I think going in with the expectation to talk about a lot of different topics, and to come with your own questions about your health, and to bring any concerns that you have about, down the line, cancers that might come up, or the screenings, or the reasons why we screen them, or infections, and to be able to advocate for yourself in terms of if you want certain screens versus if you don't want certain screens. I think, I've had patients who just don't want a colonoscopy. They won't do it, as Anna was describing. And I think that, is, as long as we have this discussion about the risks and benefits of getting a colonoscopy, if that's within your goals of your health, then I just want to be able to respect that. So it's not a time where your doctor is here to just tell you what to do. It's a shared decision making that based off of how you want your life to look.
Okay. Thank you. And my last question is about the ASCVD risk calculator. Is that the same? Are those people the same ones who made that? I think the medical calculator our doctor shared with that. We were talking about disparities in healthcare and how they put in a number, and when they see a Black patient versus a white one, they use that calculator. Is that from the same people who made that?
That's a great question. I don't believe the same people created that. I think I'm guessing what you're discussing is there is a lot of a very racist history of using certain calculators, especially around kidney disease,
Yeah.
that incorporated that divided people by people who are Black or not Black. And there's a lot of very problematic reasons that that was done. And there's been a lot of work recently to try to stop that practice and to remove that way that that was calculated in the system. And there's still a lot of various other calculators that often will include race as something, and that is something that a lot of people in healthcare and beyond are really actively working on and trying to stop, because it's based on a very inaccurate race-based perspective of health and healthcare. So that's a great question. The calculator for ASCVD risk doesn't include race, and is more based on other factors such as blood pressure, cholesterol, if someone has diabetes, if they're smoking. But it definitely does so there's kind of like two different ones. And I don't believe it's made by the same people, but it still is a major issue that, especially ones that include race, very problematic. So yeah, it's an active area of work and is really important to bring up. So thank you for mentioning that.
Absolutely. Yeah, I think it was like your risk of cesarean if you're Black, or that what they use to calculate, like, yeah, I think that was American Medical Association, probably. I think when we were talking about it, was mentioned that. Yeah. Thank you for answering that. Does anyone have any more questions or comments for our doctors? Oh, there was someone, I just completely forgot. Someone on our Facebook group, I posed, like, our doctors are coming tomorrow. Do you have any questions? And a mom was complaining about being really tired. She said even after she gets 9 hours of sleep, I mean, she has kids, yeah, but she's like, I'm just tired and exhausted, sleepy. And I told her, have you had your blood draw done? And she said no, but she is taking some supplements. And I said that I would pose the question to you guys. So
Yeah, I mean, that sounds very difficult for her to get the recommended time of sleeping and still feeling really tired. There could be something going on that she should go and see her doctor about. Things that are coming to my mind could be a low blood count, so anemia, that can be causing fatigue. So I think definitely going to get a better history of how long this has been going on for her, and getting some blood work done could be helpful for her, especially if this has been going on and affecting her daily functioning in life.
Absolutely. Thank you. I know when I had there's a question in the chat I'll get to. I know when I at a point in my life I experienced the same thing, and my medical doctor couldn't figure out what's going on, and I went and saw a naturopath, and she drew some extra labs, and I found that my DHEA levels were really low, and so we had to start me on a supplement. At the time I was breastfeeding, but then she started me on a low dose, and it was very helpful because I could barely keep my eyes open, and it was just draining, like exhausting. Didn't know what was going on. Yeah. So because apparently, like, medical doctors they just have to do a certain level of tests, and they can't, like, if they check off, like, okay, this is normal for this is normal, they don't go beyond those tests. And so she was able to go beyond that and then found that out. So yeah.
I'm glad you had that experience. Yeah, I think when someone comes in, it definitely seems like something that she should go and see a provider for, to try to work it up.
Absolutely.
There's certain things that like Helena mentioned, in terms of anemia, or things with the thyroid, or things with challenges with, she might be sleeping enough but have like a sleep apnea or challenging sleeping, or sometimes depression can manifest in being really tired, and so there's a lot of different things that we think about when someone is fatigued, and it's important to really take seriously. And I think that goes into the question I'm seeing here of, like, how to empower folks to advocate for themselves when they feel their doctor might not be taking their concerns seriously. And I think that's such an important question. And I think I can say for myself, and also for Lena and the people that have gone into our profession of family medicine and have chosen the program that we're in, is that we're really passionate about this topic specifically. And I think really empowering folks to come in and feel like their concerns are taken seriously. And I think there's so many experiences in the healthcare system where people don't feel that way, and feel really like they're not taken seriously for their concerns, and a lot of that often can be related to racism and can be related to sexism and a lot of disparities that exist. So I think that just like knowing that if you have a provider that's like not listening to your concerns, either finding a different provider or really like having things that you like, sometimes like writing things out for yourself can be, if that's something that's available to you, is like writing out like, these are the things I want to make sure I say, because sometimes it can feel like the power differential can be really challenging, and as much as some people try to break that down, it can be really hard when you're in that in a visit and you just forget what you want to say, or you feel like you're being shut down. And I think that should not be something that people experience, and that you should go to a different provider. That is not belittling, but I think so that one strategy is having stuff written down, having someone with you in a visit can be a really helpful thing, that can help advocate for you. And I would say those are the ones that come to mind. Lena, do you have any other ones you feel like are helpful for folks?
I agree. This is so challenging. I think I want to echo that, the patient and doctor relationship should be, the foundation should be trust. So I would hope that patients are able to trust their doctors, and to be able to feel heard, and like they're able to express their concerns, and to let their doctor know that they feel like they're not being heard when they are experiencing that. Just so I think just letting your doctor know that can open up the floor to exploring that relationship deeper. And I think there is also value in finding a doctor that suits those needs for you too. So finding a doctor that fits for you, because I think it's difficult to be assigned a doctor and feeling like you don't have a good relationship. Feeling like you are able to go and find a different doctor is definitely in your right as a patient.
Great questions. Yeah, absolutely. Yeah. Cool. Those were all of my questions. I was writing them down while you guys were saying, so I wouldn't forget them. So that's awesome. So will you doctors be coming back to us, be coming here for a while, or will there be others joining you for our upcoming sessions?
Yeah, I think it's varying by the session, but I believe I've signed up for one in the future, and I think
Awesome. Okay.
we'll be back. We'll be back.
Okay.
We will.
So we can't wait to have you guys back. Yeah, thank you so much.
It's been so nice to be here, and really appreciate you all being here and taking the time to speak with us.
Yeah, thank you as well for coming. Yeah, thank you. I will communicate with Dr. Abram about our next topic, and just talk amongst ourselves, and then let you guys know. But thank you so much. Yeah, have a good night, guys.
Bye. Thanks, everybody.
Yeah.